Hello, my name is Abby Joseph. I'm a medical student at Herbert Wertheim College of Medicine in Miami, Florida. I'm speaking on behalf of our team, composed of fellow medical student Jasmine Nario, attending physician Dr. Guillermo Izquierdo Pretel, and resident physician Dr. Regina McPherson of the Jackson Memorial Hospital Internal Medicine Division. We wrote the following case report entitled Anabolic Steroid and Adderall-Induced Rhabdomyolysis. This report describes the synergistic effects between anabolic steroids and amphetamines, causing an uncommon precipitating factor, rhabdomyolysis. The case is centered on a 41-year-old male, single dentist with a past medical history of generalized anxiety and illicit drug use, who presented with epigastric pain and profuse non-bloody vomiting. The patient reported a history of self-prescribed trenbolone use for about 1 year, last used 1 week prior, as well as daily prescription Adderall. The patient also reported a non-productive cough as the initial symptom a week prior, then epigastric pain and vomiting that started 2 days prior to presentation. In regards to the clinical course, prior to admission, the patient reported trenbolone 400 milligrams weekly, consistently for 1 year to enhance his gym performance, and daily Adderall use. Moreover, he reported historical cocaine use and daily alcohol use, as well as prescription Xanax, bupropion, and finasteride daily. At the initial presentation in the ED, the patient presented with an initial CPK of 1,308, sodium of 133, white blood cell count of 22.4, hemoglobin of 16.9, AST of 110, and normal creatinine. Other labs were within normal range. Toxicology screen was positive for amphetamines only. A diagnosis of rhabdomyolysis was made, and treatment with IV fluids begun. The patient was admitted, and the days following an infectious workup revealed no clear source of infection, so leukocytosis was attributed to steroid use. The patient remained afebrile and hemodynamically stable. After 5 liters of normal saline, CPK repeated was 12,190. This rise coincided with a rise in AST, increasing from 90 to 177. IV hydration was continued and prevented any deterioration in renal function. After an additional 2 liters of normal saline, CPK was 5,887. CPK continued to downtrend with concomitant oral and IV hydration. There remained no evidence of acute kidney injury and electrolyte abnormalities resolved 3 days post-admission. 2D echo was negative for steroid-induced cardiomyopathy. Treatment was continued with oral hydration, and the patient was discharged 5 days after admission. The patient was discharged with a CPK of 969. Follow-up with the patient revealed repeat CPK 1 week after discharge at 215. It is believed that this patient presented with a delayed onset of rhabdomyolysis, likely due to the synergistic effects of anabolic steroid use and Adderall. This case illustrates an uncommon presentation of rhabdomyolysis yet to be discussed in the literature. Given the increasing prevalence of anabolic steroids and Adderall use, this study is aimed to alert our community about the potential danger of their synergistic effects, given the current scarcity of knowledge surrounding their physiological interaction. This case illustrates the need for further investigation and research of the possible synergistic effects of anabolic steroids and Adderall on rhabdomyolysis. Overall, anabolic androgen steroid use is a public health threat, and the primary provider should be alerted about its potential danger and educate our community to avoid self-medication. Thank you.